for. Okay, now we're being recorded. Okay, so thanks for joining everyone in broadcasting live from the western end of the Upper Peninsula. So I hope technology cooperates. So just to get started, though, we are in a truly extraordinary time, with this pandemic that is upon us. And as sort of a backdrop for that, I just want you to know that, there's been a lot of folks in public health and in public health registries, immunization information systems, the other name for them, who have been really preparing for this sort of response for a long, long time. And I hope to point out how that is exactly the case in my talk this morning. So I'm going to start out by saying, okay, let's talk a little bit about what immunization information systems are, and then get down to the meat of the matter, how they can support local and statewide response to a pandemic, as well as looking at what sort of systems might be in place or being put in place to support a national response. So let's get right down to it. If you're the textbook version of the definition for an immunization information system, they're typically referred to as confidential, my emphasis here, population-based, computerized databases that record all immunization doses gathered by any immunization provider to persons living in a particular geopolitical area. And my little schematic view of that is this. So, key thing, population-based, and it's comprehensive. All of the different immunization providers in this jurisdiction will report to the registry. So in my little schematic here, the immunization information system is the hub, and the spokes might be, let's say, Michigan Medicine or St. Joe's, public health agencies, schools, universities, retail pharmacies like Walgreens, CVS, and the like, and then private practices, ABC Pediatrics or wherever it might be. All of them report into the centralized immunization registry to share the information. And so what we have then is one unified record of all providers, all doses. And that's a big deal, because if you think about it, if you go to your own, let's say we go to Epic and we have the University of Michigan system, what you have typically there are going to be the doses that were administered by the University of Michigan. And so you have that view locally, but the registry is really that population-based view. So we have this record of all doses that are administered, but an important point I want to share with you folks this morning is there's a lot more in that registry other than just the doses. When a child or a person is offered a particular vaccine and they refuse, that refusal can be also documented as a non-administration, is what we call it. We can also document immunity. Let's say a child has chickenpox and is no longer in need of the varicella vaccine, for example. We also track waivers for school attendance. You're probably aware that schools require certain vaccines for attendance, and at times parents may need or wish to get a waiver, and those waivers are issued and tracked at the individual level, actually at the dose level for individuals. So these are population-based systems. We have all kids linked to a birth certificate. These immunization information systems, as children are born, they are fed by these registry systems to make sure that that denominator, the population, is as complete as possible. Another important function of immunization registries are the vaccine inventory management. And some of you may know that this is actually really complex stuff, and it's actually a challenge. Well, these immunization registries are well suited to that, and they track vaccine inventory from a couple of perspectives. From the practice perspective, so let's say in my pediatric practice at ABC Pediatrics, I can keep track, of my doses. But we can also, depending on your authorization, let's say you're the Washtenaw County Health Department, you can actually look at all of the doses available for a certain vaccine across your jurisdiction, Washtenaw County. The doses are tracked in two key different ways. We have doses that are purchased by the federal government under the Vaccines for Children, VFC program. Those are in their own sort of inventory. And then the private stock, the doses that will be used for persons with private insurance or cash payments, those are in a different stock. Those are separated in the immunization information systems. The products themselves, you'll see here in my little picture, you know, I don't know if some of you have seen this or noticed this, but the actual vaccine products have two-dimensional barcodes on them that encode things like the product name, the lot number, the expiration date. That is able to be, we are able to then use barcoders to actually track our vaccine inventory as it moves through the workflow. Okay. Another important feature of the immunization information systems is decision support. And I'll tell you why this is really important. You may know that if you have a specific individual, let's say a patient presenting themselves, take that individual's date of birth. If you have their history, their vaccination history, you can evaluate their eligibility for vaccines at that point in time based on national recommendations. So you would know whether or not they are up to date or not, and whether or not they in fact are eligible or coming due soon, a forecast for eligibility coming due soon. Well, I wanted to share with you a little tiny bit of history here. Let's go back 30 years or so. That ability to determine what a person is due for at that moment in time used to be really simple. So for kids, this is the primary vaccination series going back to the 80s, late 80s. And quite honestly, providers could do this mostly off the top of their head, or they might refer to their little cheat sheet on a card in their lab coat pocket. But this is pretty simple stuff. Decision support was basically, look, the kid's 2 months old, they're getting polio, they're getting DTP, and that's what they got. It was basically very simple, no need for any other assistance, really. It was most times done out of the providers, right out of their own head. So it's no longer that way. You may have seen this before. This is the CDC published Child and Adolescent Immunization Schedule, which has been approved by the Advisory Committee on Immunization Practices, otherwise known as ACIP. I don't expect you to read this at all. It's not necessarily what I want you to know is we've got a lot of vaccines in this list. We have 15 of them listed, and we have a really complex schedule, sort of this, you know, this fruit salad of different timings and different doses and whatnot. And it's complex as is, but heaven help us if we get off of that schedule, and let's say the child is sick and can't get a certain dose, or perhaps the parent opts to sort of stretch out that vaccination schedule because they don't want kids getting all these doses at one time. Things get really, really complicated. Immunization information systems can handle that. They understand this schedule and all the variations of it, and they can still evaluate that complex situation in these decision support engines. So that's a very important function of these registries. Just a quick word on the Michigan registry, something I've worked with actually since before it was even born, back when it was a little embryo. The Michigan Care Improvement Registry, MICR as it's known, began its actual operations in 1996. And again, this is one of these birth-based registries where all births are added directly and immediately into the registry, right from our state's vital record birth registration system. All immunizations providers are required by state law to report all doses administered to children under 21 years of age. So the law says you got to report. Now, what's interesting, Public Health Code also says that the registry is authorized to accept doses for persons 21 and older. So that makes our registry a life course registry. It's mandatory for kids, but it's authorized for adults. And that's a big deal, especially as we go through our talk today and are looking at pandemic response. I just want to make clear about the public health law in Michigan. All right, so a few fun facts. So in Michigan, we have roughly 300 babies born a day. So those within usually a week. Sometimes it takes a little while for births to be certified, as a lot of you are aware. Babies sometimes even leave the hospital without a name, you know, and so it takes a little while for those details to be added and having birth certificates formally registered and certified. But within a week or so, you know, hello world, those babies are in the registry, and oftentimes they carry with them their hepatitis B dose that might have been administered on day 2 of their life. So that comes right into the registry with the birth certificate. So we have that denominator being built as those babies are being born. It translates into roughly about 16,000 doses being added to the registry each and every day. In total, over the years, we have something like 10 million people included in the MICR registry with over 150 million total doses accumulated. And of course, each and every day, more and more thousands of those doses are being entered. Just want to share with you a couple images of the MICR registry. Again, sort of a historical fun fact. Back in the day, let's go back to the 90s, you may or maybe not know, there were no electronic medical records. Those did not really exist except in extremely rare instances. Some institutions had them, hospital-based institutions. So really, immunization registries were the only game in town in terms of office automation for medical practices, certainly to track vaccinations. And here we see this is actually the current web version of MICR, where you've got the vaccine series listed in the rows, and the columns are all the different doses that were administered to this child as they progress through the schedule and the specific product that was administered. And then also there's a sort of a call out there saying what is up to date, what's overdue, or what's complete. So at a glance, a person can understand for this particular person, in this case, a child, what they are due for. So the MICR registry has those types of views, and which again was the only way to really understand child to date or not from an automated perspective in that era before electronic health record. A historical view, this is a chronological view, all sorts of different views. One of them, this is an excerpt from something called the Michigan Official Vaccination Record, which the reason I put this up here, it's actually the same information that you just saw, basically the vaccine series here on the rows and the different doses that have been administered. But this is oftentimes printed in clinic by practices. What they'll do is they'll queue up, let's say, our appointments for tomorrow. All those children, a medical assistant or nurse or administrator may pull up each of those MICR records, print them off, circle what the child is due for. And actually this paper oftentimes follows that child through the workflow as they come in for their appointment the next day, and providers record things, and then they'll use this as sort of a kind of a working sheet as to what was actually offered to the child, what was administered, and if anything was refused or wasted or any of that kind of stuff. And so it's sort of a paper trail in clinic, which is commonly used to this day, even though, of course, this information is all automated. So that's sort of the 101 of what immunization registries do, and a little sneak peek into how like MICR operates. But what I want to do is sort of switch gears and talk a little bit about how that functionality can be applied at the local level and at a statewide level in terms of some pandemic response, okay? So if you take that functionality, clearly as a person comes in, let's say, okay, we're in the middle of this COVID pandemic right now, I walk into my primary care clinic, they can use this information in real time to assess whether an individual, me, is up to date or not for my COVID vaccine. So at an individual level, the systems are very well suited for that sort of thing. But these systems also allow reminders for sort of preemptive notifications. You are coming due for something. And that's certainly true for COVID vaccine, where we might have a 2-dose series, and I could get a reminder saying, hey, you're in 10 days, you need to get your second dose of COVID vaccine. Those kinds of reminders or recall when you're overdue. You can get notifications sent out by the registries as well. But unique to registries, of course, are this jurisdiction level vaccination view, where we can sort of go up at a population level and say, hey, look, for all of Washtenaw County or all of Marquette County or wherever, here are our COVID vaccination coverage rates for this particular county. And you may be able to reveal certain areas that, as we call them, are pockets of need to do outreach using the reminders. As I had mentioned, these immunization registries have sophisticated inventory management and tracking systems. And so you, as a public health official, may need to redistribute vaccine product from one practice in one end of the county to another, or as happens sometimes, there's short dated vaccine that's about to expire. Sometimes they move that around to basically ensure that it doesn't expire while it's waiting to be administered, and they move it to a different practice to make sure it moves out. So the immunization registries support each of those functions quite easily. But going back to my sort of schematic, remember I'm saying as we meet the challenges of this pandemic, we are connecting all these different immunization providers, these stakeholders, whether they be health systems like the Michigan Medicine or St. Joe's or public health agencies, health plans, Blue Cross Blue Shield, consumers, you and I, all of those stakeholders need to be connected to this registry in some fashion to effectively respond to the pandemic. And if you think about it, let's look at it from the provider perspective. There's this enormous diversity of electronic health record systems out there. We at Michigan Medicine use the EPIC system, but there are many, many different EHRs being used across the state, dozens in fact. And so these immunization information systems need to be able to speak in real time to this diverse selection of EHRs, and not only allow us to push information up to the registry. Remember, we have to report in Michigan by law, all those kid doses have to go up to the registry, but also likewise, we need to be able to pull that information down so that we can actually have that consolidated record at the point of service. In your office, when you're seeing your patients in primary care, we want to know at that point in time, is this child due or not due, using complete and accurate information. That sort of exchange, that bi-directional exchange that some of you have heard me talk a lot about in real time, is actually crucial, and it hinges on something that I've underlined here for emphasis, one of my favorite topics in health informatics, standards. It all hinges on the use of standards. I'm going to take a little excursion here for a couple slides to talk about standards, but before I do, I just want to remind you, in sort of the days before standards and office automation, this is what practices looked like. And, this is not 100 years ago. Actually, I took this picture, I think in 2010, just as electronic health records were just in their infancy in the state of Michigan. But you can very clearly see how we tracked vaccinations and really everything else in the patient record. Here they are, neatly organized in paper folders. This is the way it was. That's the only thing we had. And the only office automation we had at the time, because electronic health records were essentially non-existent, not just in Michigan, but just nationally. They just didn't exist. Our office automation was immunization registries and the fax machine. So if we were doing exchange, it was invariably by fax. That's what we had. So that's the world we lived in 2010. Well, since then, we've adopted standards slowly but surely throughout the industry. And the only way the exchanges that I'm talking about can actually be accomplished is through this use of standards such as procedure codes, diagnosis codes that most of you are at least familiar with. Lab results are encoded by something called LOINC code. And even when we have things like non-numeric data, like narrative data, there's nomenclature vocabularies, SNOMED, that are used to capture that. And whatever that information is that's been encoded in those ways, those data content standards, the key for the exchange that I'm talking about today is the last bullets, which are data format standards. Think of that as being sort of the electronic envelope that we send this information along in. And so I boiled down actually an hour-long lecture into 2 bullets here, which is what you need to take away is that data format standard that's important here today about immunization information systems is HL7. Health level 7 is a message format that very, very nicely supports this bidirectional exchange, pushing immunization records up, pulling them down from the registry. It's made for that. And it is widely adopted throughout healthcare IT. This is not simply a standard that has been adopted by immunization registries or electronic health record systems. this is not just a national standard, this is a global standard. This has been around since the mid 80s, actually before even immunization registries, and is very, very well established and used widely. So this is crucial to the kind of exchanges that we need. So back to my little schematic, when we look at the hub here, that immunization information system, those vaccination providers, whether it be health systems or health departments or private practices, are not only pushing information up to the registry or pulling it down using those HL7 messages, which have been enabled in the registry and their electronic health record system. So how did that come about? Did everybody just wake up one morning and just decide, hey, we're going to do HL7 from now on? Well, actually, going back to the era where I showed you that photograph from that pediatric practice, in 2009, when I was going out to those practices for another CDC-funded study, there were no electronic health records, none, zero. There was none. Actually, there was one family medicine practice that had a brand new system that they were incorporating, but it was so unique, okay? Well, something came along called the High-Tech Act. And if you remember the economic downturn of 2008-9 in that era, well, we had this giant stimulus act where billions and billions of dollars were sent out. One of the conduits for that stimulus money was under the High-Tech Act of 2009, which provided many billions of dollars of incentive payments to get automation out there. What did that mean? We're going to incentivize health systems like the University of Michigan to get EHR systems. We're going to incentivize private practices to adopt them. And so as a consequence, the electronic health record vendors, such as Epic, Cerner, and all the big ones, actually all of them, have widely adopted HL7 standards because they really couldn't be in business without it, because that High-Tech Act basically says you can get this money for buying an electronic health record system. And oh, by the way, you can get even more money if you connect with a public health registry. Like, oh, really? And so if you connect with, let's say, an immunization registry, you would be eligible for a greater payment. Well, it worked. Practices adopted interoperability due to those incentives. And this real-time reporting that we're seeing now today is timely and complete, excuse me, because of those standards being adopted by the vendors, and of course, by practices buying those EHR products, which, as I said, in 2009 largely did not exist. So as a result of this sort of widespread adoption of HL7 messaging through electronic health records and those connections to immunization registries, we have what I refer to, this is my terminology of the interoperability dividend. By that, I mean, these are benefits that are realized by basically removing barriers. We make it really, really easy for people to report. And as a consequence, it has data quality implications in a good way. We have more timely, complete, and accurate information. If you humor me for the next 4 slides, I'm going to show you exactly that how that worked in Michigan. This is the interoperability dividend. So let me orient you to this slide. First slide here is for children doses. Kids, in this case, 18 and under, reported to the MICR registry between 2010, and that's on the x-axis here, on the lower axis here, you'll see between 2010 and 2019. If you can read those numbers, it's around 5 million-ish, and you can see here this is hovering right around 5 million steady over each of those 10 years. Okay, so not surprising that we have steady reporting, because guess what? It's the law. In Michigan, you have to report. But here's the interesting part. So what I've overlaid here are stacked bars that show for each of those, let's say 5 million-ish doses that were reported to MICR in each of these years. Let's go back to 2010 here on the far left. And so what this says is that it's a stacked bar, stacked to 100%, obviously. The hashed part says, you know what? 75% of those doses at that time were entered by a good old-fashioned keyboard. Somebody stood there and entered these by keyboard. And the remainder of those were entered by something we call electronic file transfer, which would be large health systems, let's say like University of Michigan, would say, no, you don't have to actually do this by keyboard. Every night, we're going to extract some of this stuff from our own internal systems and send it to MICR automatically. So the large health systems had the capacity to do that. So in those days, you would have this electronic file transfer. And so that's what you would see. Now look at here. In 2012, that's when MICR started accepting HL7 messages. And that's when the High Tech Act really started to kick in. Practices started to have their electronic health record systems acquired. They started using them, and they started wanting to report to the registry. Well, so you start to see those messages. These dark blue slices of the stack are now HL7 messages reported to the registry. And what you see is this very clear upward sloping up to about 2/3 of the doses now reported to MICR are in fact by HL7 for kids. That's not too surprisingly, as I said, because the law in Michigan says, thou shalt report. Here's the fun part, and this is the interoperability dividend. Let's look at adults. So over the exact same time period, same orientation of slide here, except now we're talking about adults, 18 and over. You go back to 2010, this very obvious increase of doses, starting out with about 1.5 million-ish doses back in those days, and up to over 5 million today. Okay, so a very substantial increase. But here's the fun part, folks. Go back to my stacked bar showing how those doses got in there. Why would there be such an uptick? Well, I can tell you why. If you look back in those days, just like with kids, hundreds of doses in the 2010 were either entered, of course, by either keyboard, somebody stood there and entered them, or else there might have been an electronic transfer of files. But again, in 2012, we see this steady increase, but it's really steep for adults, where you have now, as of last year, 85% of those doses being reported to MICR are through HL7. So let's just pause for a second on that. So remember, in Michigan, there is no requirement that the public health code does not require those doses to be reported. So, but they're being reported at an amazing volume, and it's just growing and growing and growing. And friends, this is the reason right there, that HL7 piece. Get my cursor to work. The growth is because it's easy. Why is it easy? The preponderance of practices in Michigan are either family medicine or mixed group practices. And so if they see kids in their practice, they have to be set up to report. They have to report to the registry. And so if they report to the registry for kids, it would be more work to not report those doses for adults. And so there's that dividend I'm talking about. We set up the systems, and we basically open a conduit that says, okay, we're connected to MICR, let's report immunization doses. Excuse me. And so now very clearly the kids are going into the registry as required by law, but so are adults. The reason that this is so hugely important in this time of the pandemic is now, not only do we have that population denominator, I know the epidemiologists on the call will love that, denominator. The kids are there for sure. They're coming right out of the birth registry, but now we have the adults. I showed up at Dexter Family Medicine, and I got my flu shot. Well, I'm in the registry now. So the registry not only knows about me, but the denominator, new guy, Kevin Domkowski, but it also knows that event that occurred. He got a flu shot. And so we now have a far more complete registry as a result of HL7, and it's not really costing those practices anything more. So I really love to show that slide. Thank you, Hannah, for putting that together each and every year, because it's really helpful. So as a result of that interoperability, this bidirectional sharing, which is so crucial now during this pandemic, it allows us to have complete vaccination record at the point of service. Right there in your clinic where you're seeing that patient, that child, we know right there via this connection to your EHR that kid has already gotten their COVID. Okay, so we will know that at the point of service. But even more so, those connections will allow the return assessment of that immunization, excuse me, information system decision support assessment back down to an EHR. That result can be pushed back down to the EHR, so we can know through that complex decision support logic, is this person to date or not? That can be pushed down, and the information in an electronic health record system, which is native to that system in the clinical record, can also be combined with that information and say, hey, wait a minute, we got this information from the registry and it's complete and up to date. And we also know that here are our COPD or asthma patients or whatever, or who have cancer or other chronic conditions. We can identify high-risk patients if we wish to do outreach to those high-risk groups. And we can also use some features that are native to those EHRs, which are really actually pretty sophisticated. We all know that there's portals, patient portals, which are linked to the registries. There's other reminder systems, whether it be text messaging, phone call messaging, or other forms of messaging that are built into these EHR systems, and they're actually really, really helpful, and they are then further enabled by the information that came down from the centralized registry. Last thing I'll say, of course, is back to the vaccine inventory. We are going to then have the ability to look centrally at that information at your practice to understand what your inventory looks like, and perhaps you need to share with another one of the practices in your health system, shifting from Canton to Brighton or whatever, that sort of thing. Or a health department may need to switch or move around some doses within their jurisdiction to balance things out if shortages are occurring at one end of the county versus another. So these all can be done using that sort of interplay between the immunization information system and EHRs as a result of that interoperability. All right, so I just want to do a quick shout out here to our CHEAR colleagues. We are very busily working on interoperability in our own work. For years, we've been supporting the MICA registry, looking at this HL7 messaging since the beginnings of it, actually even before the beginnings of it, looking at data quality in the registry, and also looking at the impacts of interoperability on provider practices in terms of their workflow, especially during this time of pandemic or even just the annual flu season. Other health systems that we, or public health systems that we support include the Childhood Lead Poisoning Prevention Program, the CLIP program, which actually uses HL7 messages just like we do with immunizations. It's a different type of message, but the same idea to report to the state registry, as well as some new work that we're doing with newborn screening orders and results being sent by HL7. So the last portion of my talk, I want to switch gears to now sort of a bigger challenge. Let's look at the national pandemic response using IAS, okay? So let's start out with one element of the challenges. Okay, you probably know from watching the news or listening or seeing news releases that we clearly have this big Operation Warp Speed, push to get a vaccine out for COVID. Right now we have, I believe, 4 leading contenders, 2 of which are on the verge, I believe, of seeking authorization to become licensed for distribution and manufacture and distribution. Those 2 new vaccines are 2 vaccines, 2 dose series. So in other words, you get an initial dose, and then 21 or 28 days later, you get a booster dose. So you need 2 in order to get the complete immunity. Well, 2 of those vaccines the first 2 happen to require extreme low temperature for preservation. And when I mean extreme, I'm talking about 80 degrees below 0 centigrade, which is like what, 130 degrees, something like that, below 0 Fahrenheit. Crazy. So this is transportation challenge, unlike anything we see in vaccinations or vaccines in history. Any vaccine requires at least refrigeration, so something called the cold chain is important. We're set up for that. That's an important feature in terms of tracking vaccines to make sure they remain refrigerated. This is different though. This is 80 below 0 centigrade. That is like crazy cold. And there's going to be specialized tracking and whatnot to make sure that those doses remain frozen at that temperature until needed. If you want to read a really interesting article, there was something in the Washington Post 2 days ago about just how does this all work. I encourage you to read that. Here's a link down here. It's really cool. So here's the challenge, and I'm going to talk about this for the remainder of our time this morning. Okay, so let's say you and I were HHS, the Federal Department of Health and Human Services, and/or the CDC. What do we ultimately want to know about COVID vaccine? Well, amongst several other questions, we want to know where the vaccine supplies are. Okay, where is it? How much has been administered? And like, what is our vaccination coverage for COVID nationally? That's what they're trying to do from a national perspective. So here's one big giant wrinkle. We do not have a national immunization information system. So like, how are we going to do that? right? I mean, it's like these are great questions. And actually, if you think about it, those three questions at a local level, state of Michigan, that's what immunization information systems can do. But guess what? We don't have a national IS. So now what are we going to do? Well, we don't have a national IS, but here's what we do have. We actually have 64. 50 states, plus District of Columbia, plus 5 cities, which you can see over here on the lower right, which have been delegated authority to track doses by their states. And then we also have 8 territories: Puerto Rico, Virgin Islands, Guam, American Samoa, and several other smaller jurisdictions in the Pacific, Micronesia, et cetera. So we have 64 different immunization information systems. That sounds pretty daunting, but here is the good news, newsflash. They all speak HL7, each and every one of them. The CDC has invested heavily over the past decade to make sure that these registries, they can all be somewhat different and they can all meet the needs of their specific state, but they need to have a common framework technologically, and they do. And so this is the good news, folks, is we are well poised for this moment where these registries, if they need to exchange information, are actually all speaking HL7 and they're all standard. Okay? So here's what I want to talk about for the next couple of minutes here. We've got 4 different strategies that the CDC has put together to address the needs that they believe are out there for exchanging and tracking COVID-19 vaccine. And they have 4 different angles. I'm going to walk through each of these to the best I can, but I'm going to tell you right now, my little disclaimer warning at the bottom here, this is changing rapidly and it is a little confusing, I have to admit. And part of the confusion is some of the stuff is just literally, like being developed as it goes. These concepts are being changed, modified. This is all happening in real time, folks. So I'll do the best I can do based on the information that we have at this point in time. Well, I share this not to confuse you, but this is in fact what the CDC, how they envision this whole process. And I want to boil this down into terms that you and I can understand, which is, look, let's say we're Health and Human Services down here. And we want to know at Operation Warp Speed, like where the vaccines are, who's got them, and all that sort of stuff. These sort of dashboard level kind of questions for the whole country. The only way we can do that is to get information pushed down from all of those registries. And as I will explain over the next few slides, it's not quite that easy, okay? The technology exists. Those standards, as I've been trying to impress upon you, exist. So the technology part is actually not that hard, actually. It's some other sort of policy and legal procedural things that tend to get in the way. And so as a consequence, the CDC has built some of these layers to try to address and even sort of sidestep some of those potential barriers. Let's talk about it. So the first thing is this immunization gateway. This is actually an important thing that says, look, we've got all those systems out there, 64 immunization registries. We have to have some common place where they're all going to link up to so that they can use that standards-based approach between each of the immunization information systems and the CDC and their systems to connect, okay? So we want to enable all of the authorized agencies to connect. So that's our goal here. So how are we going to do that? Well, that immunization gateway functions sort of like a health information exchange. Maybe you've heard that term, HIE strictly for immunization. And there's a lot of connections. If you think about it, each of those 64 jurisdictions, if we want to connect with all the remaining 63, if you go through and do the math, that actually turns out to be over 2,000 different connections. So building those individual connections is sort of a non-starter. So that's where the IZ gateway comes in. It actually says, no, don't do that. Just connect once. You connect in Michigan to the immunization gateway. We take care of the rest. The immunization gateway is sort of like a hub, and it will connect it and take care of the connections to all the remaining immunization information. So that's how this is going to work, sort of a spoken hub type of model. Here's the thing I want to emphasize, and I will probably do this 3 or more times before we're done here. The challenge here is not that technology. Actually, that sort of linkage I just described is actually not that challenging for the CDC to put together. It's the last bullet here, which is all the memoranda of understandings, the MOUs, the data use agreements, excuse me, that must exist that say, on a legal perspective, the state of Michigan is authorized to share with Ohio, New Mexico, Massachusetts, New York, everybody. That is actually a pile of legal documents and agreements. And so the immunization gateway is going to handle all of those common agreements in a centralized way. So that's an important function as well. So there's a technology function, but there's also a legal framework function. Okay. So there's another important part of this, which is it's also going to connect other agencies that don't ordinarily connect to immunization registries. You may not know that the Department of Defense, the Veterans Administration, Indian Health Service, as well as the Bureau of Prisons, they administer a lot of vaccines. And we're going to want to know where those where the vaccine is in those institutions and where it's been administered in order to have that complete denominator and the complete numerator to do our tracking nationally. So we're going to want to be able to track that, monitor that across all jurisdictions. And at some point, as people travel, once we start traveling again, that sort of exchange will allow your information to be accessible to authorized parties wherever you go. It's not clear at this point in time how it will be used, but it could also be used as a foundation for proof of immunization to get on an airplane, or proof of immunity, you know, I had COVID or whatever. So none of that has been figured out quite yet, but those are technologically possible. Okay, so just a quick wrap up then on the IZ Gateway. I'll tell you that the legal authority, though, for all of this, it resides with state and health departments. So there is no federal authority. The feds cannot insist that states do this reporting. And not all state law permits reporting to the same extent. So this is our important potential barrier. Rhode Island may wish to report, but their state law prohibits it. So, you know, if you're like me, you might have some concerns, regarding identifiable data, which is what they're requesting to be reported to the Immunization Gateway, is identifiable, meaning names and faces. Kevin Bukowski, who lives at this address, who has this contact information. And as you can appreciate, not all people necessarily want the federal government to know where they are. Okay, and I think it's safe to say that that could actually have some impacts on uptake of COVID vaccine acceptance and administration by persons who wish to not be documented. I think that you could understand that scenario and other ones like that. So there's another system that I just want to quickly talk about that CDC has put together to sort of sidestep some of the issues. There may be the ability for states to report to another system, which is sort of another layer they put out there, VAMS, Vaccine Administration Management System. CDC says that they believe that we need to support mass vaccination in a better way that's not supported by immunization registries. And it was envisioned to fill that niche and also track vaccine nationally. It has some other features and functions to support the needs of employers. Do all your employees have COVID vaccination? That sort of thing. And going back to the summertime, CDC had said, you know what, VAMS use was going to be mandatory. Well, there's giant pushback from the states. They're going like, you know what, first of all, a lot of functions in the VAMS system were viewed as being redundant with existing immunization information system functionality. And they were also requesting identifiable information, which, as I said, was not only giving people some heartburn, but they also said, state law may not even permit it. Now CDC says that VAMS is optional, and but it will connect with this gateway. So if you wish to connect in your state, if you're the state of Michigan, for example, and wish to connect in that way, it will allow connection to this health exchange that I described as being the immunization gateway. So one of the primary issues, though, is that this seems to be developed just to report up centrally to the HHS and CDC. And really, the states are saying that, you know what, this is like a redundant system. Immunization registries already do this, and there's really not clear case yet being made why there's a value added to either providers in their practices or states in their jurisdictions. So I think the jury's still out on VAMS. One other system I want to mention to you is this Clearinghouse that they've developed. They're putting together another layer that says, you know what, if you can't connect directly to the gateway with your immunization registry, and perhaps state law prohibits that, or prohibits connecting to the VAM system, we're going to have a place where you can just sort of upload, and we're going to bypass some of those connections that could, in fact, sidestep some of the legal issues for reporting to, let's say, the immunization gateway, which is this exchange. So some states may be authorized to use this clearinghouse. It's possible. But it requires identifiable information so that they can accurately deduplicate people. You know, you got to know all the instances of Kevin Domkowski or even Kevin Dombrowski, so you can actually say, hey, that's the same guy, and get those sorts of instances reconciled. Well, a lot of states are either having heartburn, as I say, or are flat out prohibited from reporting identifiable data. And so that is actually continuing to be a challenge. They say, though, from the clearinghouse, once they do all that, they're going to de-identify it and then report it up to this last step, which is sort of, in my words, the sort of the dashboard system. They call it the data lake. I don't know how they come up with these great terms, but it's basically de-identified information that comes from all those systems. It's a cloud-hosted system that basically pulls in all of that de-identified data from all those different reporting options, consolidates it, deduplicates it. And the bottom line is this is what they're trying to do, is they're trying to serve Health and Human Services needs for sort of a dashboard, Operation Warp Speed, you know, so we can say, okay, where's all the vaccine at, who's gotten it, those sorts of things at that level. So in my mind, that's the primary purpose for all these different layers being pushed up. I will say, and I'll just remind you, you know, public health occurs at the local and even state level in primary care. It's not happening at the White House. Okay, I'm just going to say that. Okay, it's happening boots on the ground. And so those systems that I described earlier, immunization, information systems, and those linkages to EHR, that's where the action's at. So I will say that there are some issues that remain. The extent to which those that states will or even be able to participate in sharing data at that level nationally remains to be seen. How we use that information to document vaccination status for our ability to show up for work, to travel, all that is yet to be figured out. And how they aggregate that data into that dashboard remains to be seen. I just want to say one more thing before we finish up here. You know, I talk about the state to state variations because state law varies. The Constitution of the United States says that that authority resides with the states. So Ohio can do what they want to do, Michigan can do what we want to do, Texas can do what they want to do. Well, there's variations of those laws, and those affect what goes into those immunization registries. Some states authorize different age groups. Some are opt-in, Texas. Some are opt-out, Michigan. Actually, most of them are opt-out, which says like, okay, you're in the registry unless you check the little box and say, no, I don't want my baby in the MICA registry, okay? And those have big implications for the completeness of the registries, as you can imagine. And likewise, who reports? Public providers, private providers, do pharmacies report, schools, universities, all those different things are controlled by state law, okay? So my little analogy in my last bullet is this. So you can take all these, you know, technological gymnastics and put all this information together, but what do you really have? And I'm not sure that anybody knows the answer to this. I just want to say that in my analogy, you could use the Swiss cheese analogy and say, sure, there might be some solid pieces if you go across all those 64 different jurisdictions that you've stacked information for, but there's probably going to be some holes in there. So, you know, and so even in Michigan, where we have good reporting for adults, we don't have complete reporting. We have very good reporting because it's not mandatory by law. So when you aggregate all that up, you know, it still remains to be seen just how solid that stack of Swiss cheese is going to be. Okay? Lots of pushback on some of these ideas. I point you to a reference here. Some of our good friends, Association of Immunization Managers, American Immunization Registry Association, and others, these agencies, or these organizations rather, are representing the boots on the ground folks who take care of immunizations and public health. They are saying, you know what, this model that is being presented by the CDC is not ready for prime time. There's a lot of prohibitions at state law level, as I've mentioned, and how that flow is going to occur is not clear at all. And mainly, none of this has been tested. Some of the stuff is just being developed as we speak. None of it's been tested. And guess what? We have a pandemic right now, not next year, right now. So there's some real concerns, and so that is still being worked out. I leave you with some references here, and I guess my closing remarks will be this: even though this last segment here about national pandemic response, you go like, gee, what the heck's happening with all these different layers, and it's a little confusing. And I just got done telling you that, is it going to be incomplete? What I want to do is point you back to the earlier part of this, which says, you know what, our immunization information systems and their ability to speak with primary care electronic health record systems is solid. It's very, very good. And we are well poised to meet the needs and the demands of this pandemic at the level at which the public health response occurs. Right here, boots on the ground in clinics and at in mass vaccination clinics or in individual clinics. But we are well poised to track that information. How that gets bubbled up at a national level, some of that has yet to be determined. And that's really where some of the questions are. So I do want to thank my many collaborators, primarily Ann Cowan, Hannah Peng, and Pooja Patel, who provide lots of information along the way, which I've incorporated into this, or some of the projects that I have referenced here. And I think that we have time for other questions. If there are any, if you can go. I'm sorry?
Gary has a question. If you want to go ahead.
Gary, yes.
Hey, Kevin, thanks so much. This was fascinating.
You can shout it out.
Can you hear me?
Yes, I can, Gary.
Okay, great. So thanks so much for this. This was really fascinating. My question stems from, I'm on the task force at U of M that's going to be rolling out the vaccine that we receive and how we're going to do it to, healthcare providers, and then how that rolls out ultimately to patients in other places. And the question that is come up a lot is the issue, obviously, of mass vaccination.
Yeah.
And how or whether those things make it into MICR, how they make it into MICR. And, that's everything from drive-through clinics to, whatever it might be. And I was wondering what the experience has been with that, with something we already have, like flu vaccine. Like if there's a thing at, Target for all their employees, for their adults, does any of that end up in MICR? And if someone does a drive-through thing, what, we're not set up to do drive-through and have little computers out there that track it, even though we probably should.
Yeah. Well, I agree. So the capacity of a registry such as MICR, they do capture that, Gary. There has been actually a lot of drive-up vaccination going on since the onset of COVID, not for delivery of COVID vaccine, obviously, but for regular, primary vaccination series of vaccinations. And a lot of practices across the state have already adopted sort of this drive-up service. Basically, it's the roll up your sleeve or your kid's sleeve. And they actually do take laptops out in the parking lot. They have little tents set up and all that sort of thing. There are models for that, and I can actually point you to some practices, and some of them are not tiny. Some practices are doing this, and it's working well.
Not practices, but like in the private sector, let's say that Alterum does a vaccine thing for a flu vaccine for all of their employees. Not a practice, but a.
Okay. So that would be more likely like the, visiting nurses, that sort of thing. And so those doses do end up typically in MICR, like for flu clinics like that. They don't necessarily happen real time, like, a millisecond later, but they generally show up, let's say, in batches at the end of the day or end of the week. I hope that answered your question, Gary.
Yeah, thanks. I think the challenge with COVID is just at the scale and the time frame is daunting.
I agree. And I think that as you point out, seasonal influenza is sort of our best model to emulate because that's obviously something that tends to be like very concentrated and on large scale. But I think it's safe to say that some of this we're figuring out as we go, but there are some models for that, Gary.
Thank you.
And if others happen to have questions, after the time, I think we are running out of time, please feel free to email me. And I don't pretend to have all the answers because, like I said, there's a lot of this is just being developed as we go. But, I can try to point you to resources, but I would encourage you to click on that link at your leisure and look at that Washington Post article that talks about just sort of the vaccine process. Which, by the way, the Pfizer vaccine is being manufactured in Kalamazoo, Michigan, actually Portage, Michigan. But it has a really, really interesting article there about how that process works and inventory and whatnot. I encourage you to read that.
Thanks, Kevin. This was an awesome talk and very timely and informative right now. So I really appreciate it. And it looks like Dan put the link to the article in the chat, so people can copy it.
Great, thank you.
Awesome, thanks so much.
Well, thank you all for joining, and enjoy spring. I guess it's supposed to be warm there, so